Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynaecological Cancer. Today, I have the great pleasure of having on the podcast my dear friend and colleague, Dr. Nicole Concin, Department of Gynecology and Gynecologic Oncology, Medical University of Vienna, Vienna, Austria. And we're going to be talking about a recently published article in the Lancet Oncology titled ESGO-ESTRO-ESP Guidelines for the Management of Patients with Endometrial Carcinoma, Update 2025. Professor Concin, Nicole, welcome. So happy that you're here in the podcast. I'm really looking forward to speaking with you. It's always great to see you and talk to you.
Pedro, I'm so happy to be here. Thank you so much for this kind invitation and for this opportunity. Thanks a lot.
Perfect. Well, thank you again for accepting the invitation. And let's get started on the topic of the discussion for today. I'm going to start by asking you if you could discuss what was the reason for a need of an updated guideline in 2025, and then place this in context of the recently released 23 staging classification.
Well, endometrial cancer is really a field that changes very fast. Our last guidelines were published in 21, January 21, so it's quite a while ago. And we, by that time, covered the literature till June 19. So a lot of things actually happened since that time. A lot of new evidence, standard of care changing clinical trials, drug approvals, the new FIGO. So a lot of new things, and this prompted our working group to update the guidelines.
And Nicole, you mentioned obviously the working group, and I see lots of leaders in the field of gynecologic oncology came together for this update. How did you select the experts that took part in this new update?
Actually, we are following the ESGO SOPs on how we develop our guidelines. And what is very important to the ESGO is interdisciplinarity, that really all the disciplines involved in the management of the carcinoma are involved. So we always do the guidelines with sister and brother societies. So this time again, the ESGO, the ESTRO, and the ESP. And each of these European societies nominate their experts, their discipline members themselves. Also, we have what we call minor and major updates. And for the first update, we usually work with the same working group. So you will see it's mainly the same people than in the 21 guidelines, with some exceptions. Two colleagues have retired, and we looked for new people. So, for example, Nadim came in, Abu Rustum, in place of Dennis Kerleu. This is something new because it was actually the first time we have a non-European member in the guidelines, and Nadim was, of course, very, very valuable to have in the group. He was by that time also council member, so we have one non-European council member seat now, because the membership of non-European members is growing. So that was wonderful. And this time, for the first time, also we had the young with us. Each society nominated one young colleague, and they supported us a lot also with development of algorithm. And what is also new in composition is the patient voice. This was also a beautiful experience to have for the first time now in endometrial cancer guideline update, a patient representative with us.
That is really great. And again, thank you for putting together such an outstanding group. As you know, many of the questions for the podcast come from our fellows, and we're going to get right into some of the details of the guidelines. I'm going to start with Itzi Villagra from Spain. She's asking, there were some major changes between this new version of the guidelines and the previous versions. For instance, I'm interested in the ER status being integrated into risk stratification. Could you share the science behind that and what are the suggestions?
That is actually a very important new feature in the guidelines. And this concerns the so-called NSMP, the non-specific molecular profile. This is the biggest group of endometrial carcinomas. The NSMP make up 45 to 50% of all endometrial carcinoma. So it's a big group, it's an important group. And what we knew until recently is that this is a very heterogeneous patient population. Different histological subtypes, different clinical presentation. And what now helped is the estrogen receptor. With the estrogen receptor, we are able to discriminate within this big NSMP group two distinct prognostic group. The estrogen receptor positive and the estrogen receptor negative. And the estrogen receptor negative have a particularly bad prognosis within the big NSMP population. So this is evidence that has been published by different groups now. For example, by the Leiden group, the Netherlands group, Vermeij, she showed this substantial prognostic difference in these two patient population discriminated by estrogen receptor. So it's around, she showed this in high risk population, 90% are estrogen receptor positive, NSMP 10% negative, and the negative were really the bad guys. Another group that showed the same thing is the Canadian group. They added to the estrogen receptor also the grading, and they found that the estrogen receptor positive low grade are substantially doing better than the estrogen receptor negative or high grade, grade 3 tumors. So with the addition of the grading to the estrogen receptor, they could even better discriminate this good and bad prognosis group within NSMP. And the same was also shown by Memorial Sloan Kettering, beautiful publication, also showing that among the NSMP, the estrogen receptor negative and grade 3 really have a substantially bad prognosis. So we are now able to discriminate these bad guys within the NSMP group. And this was integrated now in the risk group stratification. So we know they have a bad prognosis and they are in the risk group stratification now.
Excellent. So moving on to the topic of molecular testing. This next question comes from Paula Mateo here at Houston Methodist. And she's asking, the guidelines encourages molecular testing on endometrial biopsy, but in certain practices, biopsy results often don't match the final hysterectomy specimen, with frequent upgrading or upstaging, and therefore repeated molecular testing on final pathology should it be recommended. Wouldn't it be more cost effective to perform it directly on the hysterectomy specimen?
So we had a lot of communication on this, the best material to use for molecular testing with our pathologists in the group, and they were very, very clear in this. The biopsy specimen, so after curettage or Pipelle, this is a tissue that is very well fixed. So the fixation, the pre-analytical process of the biopsy material is a very good one, and thus the quality of the molecular tests applied, this is mainly immunohistochemistry, that is, and sequencing for polymute. This is the ideal material to do the molecular testing. The hysterectomy specimen often has issues in terms of inadequate handling or fixation. And this can influence the quality of your immunohistochemistry. In case you have a hysterectomy specimen that after surgery immediately is put into fixation and immediately goes to the pathologist, then probably the quality is the same like with the curettage, with the biopsy material. But this is in the reality very often not the case. So for optimal pre-analytic conditions, the pathologists prefer the biopsy material. And in most of the time, also there are studies on this, you have the same result in the biopsy material and in the hysterectomy specimen.
Okay. Another question from Paula, and this one's on lymph node staging. And she's asking, what is the rationale for recommending sentinel lymph node biopsy on all patients with presumed uterus confined disease, whereas in previous guideline, it was only considered in low or intermediate risk cases and could even be omitted when there was no myometrial invasion?
Yes, I think we've all got used to sentinel lymph node biopsy. We are very familiar with this procedure. We are confident with this procedure, and and actually it is an easy in skilled hands. Of course, it's an easy procedure, can be done fast, and comes with very low morbidity. And so at the end of the day, we only know if a patient is really low risk or intermediate risk and can be discriminated from high, intermediate, high risk if we have the lymph node status. So also in the assumed low-risk patient, there can be lymph node metastasis. We know these nice studies on stage 1 low-grade endometrioid that still have 6% of lymph node metastasis. So you really only know the risk when you have the lymph node status. And as this is a nice, easy, low morbidity procedure, we now emphasize also the low and intermediate risk cases, sentinel lymph node.
Yeah. And as a follow-up to that question, Tommy Meschini from the University of Insubria in Italy, he's asking, what direction do you foresee in selecting the type of surgery to propose to our patients as it pertains to surgical management of early stage disease? Do you think we may reach a point where lymph node staging will no longer be required at all based on molecular classification?
This is a fantastic question and very important consideration. At present, we are missing the prospective data on molecular classification and, for example, frequency of extrauterine spread and pattern of extrauterine spread per molecular subtype. There are retrospective data on this, nice retrospective data. The Seneca trial has just been published in the International Journal Gynaecologic Cancer. It's a retrospective series and clearly shows differences in lymph node spread per molecular subtype, as expected, low spread in polymute, higher spread in p53 abnormal. But we're waiting for the prospective data, which are currently being collected to really have high evidence on these questions. So the EUGENIE trial from Frederica Mant and Gemelli Clinic will collect more than 1,000 patients with long follow-up, complete surgical staging, prospectively molecular classification, and will give us a lot of answers. And then when we know this, then in the next step, we can adapt surgical management in clinical trials.
Okay. Another question from Tommy Meschini is about the intermediate and high risk population. He's asking, in previous guidelines, patients classified as intermediate high risk, particularly those with substantial LVSI, could be offered chemotherapy, whereas now external beam radiotherapy alone is recommended. Can you talk a little bit about the reasons behind this shift?
Okay, this might sound a little bit complicated, or at the first sight is a difference, but so where does this come from? We saw some shifts of patient population in the risk allocation. And actually, if you look at the high intermediate risk patients now, what kind of patients are these? Which patient population is this? So if you look at the new risk group table in detail, this is mainly mismatch repair deficient patients that have cervical stroma invasion or substantial LVSI. Another patient population is the NSMP low-grade estrogen receptor positive, so the good guys among the NSMP with substantial LVSI. So this is the patient population. And if you look at the clinical trials that we have in these patient populations and the new data that we have, so this is the patient population from PROTECT 2 trial, where we saw that these patients with substantial LVSI have a benefit from external beam radiotherapy in terms of pelvic control. If you look, so this justifies the justifies the external beam such as recommended in the guidelines. There are different studies, old studies, comparing adjuvant treatment with radiotherapy or chemotherapy, a Japanese trial and another trial that showed no difference in survival. Also, if you look at the GOG studies, so the GOG 249 that evaluated external beam in this stage 1-2 high intermediate patient population versus brachytherapy and 3 cycles of carboplatin paclitaxel. We also saw no difference in the survival, well, in locoregional, but not in survival. And if you look at the PROTECT 3 subgroup analysis per molecular markers, you will see that the M mismatch repair deficient patient is really not the ones that seem to benefit from the addition of chemotherapy to external beam radiotherapy. And also in the NSMP patient population, and this is mainly the low-grade estrogen receptor positive, the chemo did not seem to play a major role. So, and as this is the patient population that is now in this high intermediate cohort, the chemotherapy fell out of this cohort and should not be given in unselected patient population of this cohort. There are some more consideration on the mismatch repair deficient non-endometrioid histologies from subgroup analysis of the B21 study. This was a study in high-risk endometrial cancer patients after complete surgical resection, no residual disease, and it included early stage disease, non-endometrioid histologies, or P53 abnormal cases, or advanced stage, any advanced stage 3 and 4A disease independent of P53. And here in the adjuvant treatment, IO was added to chemotherapy plus minus external beam. And the overall patient population gave a negative result for the addition of IO. But in the mismatch repair deficient subpopulation, we saw a significant benefit for adding IO to chemotherapy in this high-risk population. And this might be the group also in early stage disease, mismatch repair deficient, non-endometrioid, where you might deliver, even in this patient population, chemotherapy plus IO, but really for the reason to deliver the IO and not for the reason to deliver the chemotherapy. Sorry for this long.
Yeah, no, but I thank you for outlining and articulating it as such. This next question is one where I know you have had many discussions, particularly with Nadim Abu-Rustem. You mentioned him before. This one comes from Mateo Lovero from Policlinico Gemelli. And he's asking, how do you interpret some contrasting evidence on the role of focal LVSI, particularly in light of the criticisms around its interpretation and the debate on whether the extent of LVSI should be incorporated into staging and risk stratification?
Thank you for these fantastic questions. Just today, we had the ESGO course in molecular pathology in Vienna, and we had a fantastic discussion on this again. So what the pathologists tell you if you talk to them about LVSI, they say substantial LVSI, and this is obviously shown in all published studies today. Substantial LVSI, or call it extensive LVSI, or the obvious LVSI, is a very reproducible factor on H&E slides. If the pathologist looks under the microscope and immediately sees LVSI, this is a substantial LVSI. If they don't need to think about it, and if they don't need to start counting vessel involvement, it's substantial LVSI. And this is very reproducible, and it is a very strong independent prognostic marker. And all studies, also the US studies of Nadim, showed this very nicely. So the debate, the controversy is really on the focal LVSI. And here we have different retrospective studies. The big majority of retrospective studies cluster focal LVSI with no LVSI in terms of prognosis. And then there was these US studies, one from Nadim, and they showed that focal clusters with substantial LVSI. There is an other trial now, also retrospective, from the Gemelli Clinic, and they recooked the Sloan Memorial data. Beautiful. All endometrioid stage 1 endometrial carcinomas, completely lymph node staged, and they looked for substantial focal and no LVSI. And the Gemelli data actually show exactly the opposite from the Memorial data, that focal clusters with no LVSI. So the focal is really a debate. What I want to emphasize with the focal is that the focal, we really have an issue with reproducibility. And this is why I really warn from using focal for clinical decision making. This is not reproducible. This is when pathologists start counting vessel involvement. It is really prone to sampling bias. So this very much depends on how you sample, and if you look at which magnitude, how many slides you look at. So this is not a reproducible factor, really.
Yeah. So, Nicole, this next question comes from actually Mo Byrne, fellow at Memorial Sloan Kettering. And she's asking, in your experience, what is the rate of microscopic omental disease in clinically uterine confined high-risk histologic subtypes like serous carcinomas or carcinosarcomas. The recommendation in these guidelines is for infracolic omentectomy, but how often are we finding pathologically confirmed disease there? On a recent retrospective review of their own data at Memorial Sloan Kettering, the rate was 0%. So interested in those experiencing the clinical utility of actually performing an omentectomy in these patients.
Yeah, so here we have really different, also retrospective data, large retrospective series, different groups from all over the world. The numbers of occult or microscopic peritoneal implants, including the omentum or also from peritoneal biopsies, really vary a lot. But what most of these retrospective studies show is that serous and undifferentiated have rates of more than 10%, and carcinosarcoma, there is one nice study from Pittsburgh group, a relatively nice large series. They showed around 6% of microscopic disease at the omentum. So this is why we do recommend in these histological subtypes in the frame of peritoneal staging, peritoneal biopsies, and also an omental biopsy. But I agree that we should become better in this, and I think also here molecular classification will probably help in the future to guide our surgical approach. We are collecting this prospective data now. IJGC trial mentioned already is one of it. We will learn about also not only lymph node metastasis incidence and pattern, but also peritoneal spread per molecular subtype. And my hypothesis would be that this will be more precise than histological subtypes.
Okay. This next question is actually just on treatment. How would you treat a patient? And Carlota Savini from Ospedale San Raffaele in Milano, she's asking, what is the optimal treatment today for a stage 3 or 4A polymutated patient?
It would be fantastic if we had this answer to Carlotta. I think nobody really knows. The advanced stage pol-E mute cases, stage 3, stage 4, this is really a very small patient population because the majority of pol-E mute cases, they have such an excellent prognosis and we diagnose them mainly in early stage disease. But there are these cases of pol-E mute advanced stage disease. And actually all of these cases have been treated in the past. So the data we have is with treatment. Many of them have received radiotherapy. So we don't really know the prognosis of these patients without treatment. And this is also the reason why in the updated triple European guidelines, we allocated them in the risk group stratification. We gave them a gray color, meaning uncertain. We really don't know their prognosis. And thus it's very difficult to say how to treat them. I still treat them. We say we need registry data. We need to collect this data prospectively. This is, for example, done in the Rainbow trial. We say you might consider de-escalation from high-risk treatment, but really on a case-to-case individual decision in a multidisciplinary tumor board.
Yeah. This is another question on patient management from Masha Pervan in University Hospital in Münster, Germany. If preoperative staging indicated no metastases, but upon visualizing the abdomen with minimally invasive surgery, you see peritoneal metastatic spread localized to the pelvis, would you immediately convert to laparotomy or proceed with minimally invasive surgery if it seemed feasible?
It's fantastic to have all these great considerations from all over the world, obviously. Of course, minimal invasive surgery, we do it for assumed early stage disease, and we can have surprises. We can have implants, not sure what it is. If this is, maybe I would, it would depend for me on the individual patient. If I'm not sure if this is a metastatic spread, this is, I know already from the curettage, this is a low grade, a grade 1 endometrioid cancer. I'm not sure what this is. I would continue if this is easy resectable, very limited in the pelvis, do a peritonectomy, get it out. If I have the slightest concern, if I see a broader spread, if this is a p53 abnormal carcinosarcoma, I see implants, maybe I explore the abdominal cavity by laparoscopy. I'm not sure if there are other places, then I would do a laparotomy to be sure to not miss disease and make sure that there is no residual disease after the surgery.
Great. Our fellows are really taking advantage of having you here for direct clinical questions. Mathilde Del, also from now Toulouse in France, and she's asking, in a patient with endometrial cancer and peritoneal carcinomatosis, initially deemed unresectable and treated with chemotherapy plus immune checkpoint inhibitor, if she achieves a complete response at the end of treatment, would you consider surgery necessary? And if so, what kind of surgical approach would you perform?
Wow, these are fantastic questions, and we are lacking, really, we are lacking the evidence for this, but also here trials are on the way. So what we say in our guidelines, and we do not specify this further because of the lack of evidence. So if you have a patient unresectable, advanced stage disease at the beginning, and then you start with systemic treatment, and for example in dMMR patient, chemo plus IO works excellently, and then you see beautiful shrinkage, or even in the imaging no disease anymore. We evaluate the patient after 3 cycles in Vienna, and again after 6 cycles, and delayed surgery is an option. We don't want to call it interval debulking because this is not established procedure in endometrial cancer. We by purpose call it delayed surgery in the guidelines. And yes, I would go for surgery and remove what is still left over, or remove the primary tumor place in the uterus, but it's not based on evidence, really.
Great. And as a follow-up, same Matilda is asking, what timing would you recommend for surgery? What adverse effects of immune checkpoint inhibitors might increase the risk of perioperative complications? Is there any specific monitoring you recommend?
It's the same. We don't have the evidence on the best time point to do the surgery after a good response to systemic treatment. Probably most of us are reevaluating the patient after 3 cycles of treatment. So probably that's a time point where we do the surgery. Immune therapy, so this is when the patient is still on chemotherapy plus IO. So you have, of course, the hematotoxicity from the chemotherapy that you will respect before you go to surgery. You want the patient to have recovered from hematotoxicity. IO, what are side effects? typical side effects that might influence your surgery. You have, of course, immune-related associated adverse events, like you can have pneumonitis. You don't want this when you go to surgery. You don't want the hepatitis. You certainly don't want colitis. So endocrinopathy, you also want to have a good thyroid function, probably. So you will certainly not do this when you have such side effects of IO, but luckily they don't occur so often. So you will have them resolved if they occurred before you go to surgery.
Great. So let's get back to the guidelines. And this, I'm going to get to a question by Arthur Shu here from our own Houston Methodist. And he's asking, there have been some recent changes in the recommendations for Lynch syndrome surveillance, including the suggested age to begin screening and the timing of hysterectomy and biliopsal Can you give us an overview of these updates and evidence to support it?
Yeah, that's an exciting topic, because also in Lynch syndrome patients, we are starting individualized, personalized management in these patients. What we've learned is that not only the cumulative incidence of the cancers that are associated with Lynch syndrome vary depending on the specific mutation in these mismatch repair genes, but also the age of onset of the carcinoma. In our case, we now talk about endometrial cancer, but also ovarian cancer. The age of onset varies and is specific for the specific mutation in the mismatch repair gene. So, for example, the highest cumulative incidence for endometrial cancer and also ovarian cancer is in the MSH2 mutated patients. And this is also the patients where you have the earliest onset. In general, it's after 30 years, but so we start for this specific mutation, we recommend already starting surveillance with 30 years, while other mutations, MLH1, have a later onset of cancer, and you can start later. So it's an individualized approach of management of Lynch syndrome patients per mutation, which is very nice. A lot of these data were generated from the prospective Lynch syndrome database. And this also influences the time point where we recommend the prophylactic hysterectomy and BSO in these patients.
Great. So, Nicole, I'm going to go to a question from Giovanni Naveau in Memorial University Hospital in Newfoundland, St. John's. FIGO 2023 staging underpins many of the 2025 ESGO-ESTRO-ESP recommendations. Yet we know that implementation across cancer registries and national guidelines is uneven. What practical evidence would you give to clinicians in countries still using earlier FIGO versions of those who only have partial molecular testing, as an example, MMR and P53, but not wholly?
Yes, this is, I think the access to molecular testing is really a big, very, very important topic. We will, in a next step now, try to support and give guidance how to what to do if there is no full access to molecular testing, like you described now, immunohistochemistry, yes, no polymutation testing. but some don't even have immunohistochemistry. So we will adapt our guidelines to limited resource settings, to different settings, and try to give guidance on approaches here. I think there are also new features in the FIGO classification that are not related to molecular testing. And I think some of these are really very helpful. For example, what we discussed today also, where Matthias Xavier, Matthias Gouye really did pioneer work, is the discrimination of ovarian metastasis. We know today that there are a specific kind of low-grade endometrioid carcinomas in the uterus and in the ovary that is true metastatic disease, but if they have specific features, they have a very, very good prognosis, distinct from other metastases to the ovary. And this is now taken care of in the new FIGO staging system. And you don't need anything else than a pathologist and a surgeon to do this discrimination. It's really based on histological subtype, grading, myometrial invasion, LVSI. So this is a very nice feature. Also, the discrimination of peritoneal carcinomatosis. The old FIGO stage 4B patients were very heterogeneous patient population. All patients with peritoneal carcinomatosis, patients with parenchymal metastasis, patients with extra-abdominal lymph node metastasis, all clustered in one stage. Also, this is patients with totally differential prognosis. This is now respected by discriminating peritoneal carcinomatosis in the pelvis from extrapelvic peritoneal carcinomatosis, from distant metastasis. And this is helpful in having a more precise prognostication of your patient, and it's also treatment relevant. I mean, we treat these patients, our approach, just think about surgery, is different in these patients. So I think there are helpful features in the new FIGO, even without molecular classification.
So, Nicole, this is the last question from our fellows, and this one from Masha Parvan. And she's asking, which aspects of this update do you think will be the most difficult to implement in daily practice, or rather in your experience, what is the most difficult change for practitioners to accept?
That's a difficult question. I think maybe at the first sight, if people look at our risk group stratification in this guideline update and they see this table with the FIGO stage and the molecular classification and then the risk group allocation with all these colors, maybe at the first sight this is oof. But if you have a closer look, I actually think it has become extremely easy, really easy with molecular classification. But maybe this is something one needs to have a more thorough look in it. And also here we try to facilitate and support. We are now developing the ESGO app, this app application. We want to launch it in Copenhagen, where there will be an interactive tool where you can give information on your specific patient case, the anatomical borders, the LVSI, the molecular. You can type it in and you will receive a FIGO stage, a risk group allocation, and a treatment recommendation. So I hope this will be helpful.
That sounds great. Looking forward to that. Nicole, as a new tradition now in the podcast, we have as a last question, a question that was posed by AI. after reading your manuscript. So this is the question that was posed. Given the increasing evidence of immunotherapy efficacy in endometrial cancer, is it ethically justifiable that these guidelines continue to recommend conventional adjuvant strategies such as chemotherapy and radiation as first-line therapies for high-risk patients rather than adopting a more aggressive shift towards personalized immuno-oncology approaches?
Oh, Pedro. You know, this this is actually a very good final question, because this is very reassuring for you and me and all our colleagues as physicians, that we are still needed in the future and that AI will not take over our job, because this is actually not a very intelligent question. We're simply, we would love to substitute all these chemo and radiotherapy with molecularly targeted agents and immune therapy, but simply the evidence is not there as yet. All these clinical trials are ongoing, and I'm optimistic in the future we will be more targeted also in the adjuvant setting, but we are not there yet.
AI being a visionary and looking into the future. Well, thank you so much once again for this opportunity to discuss this with you. Really, again, remarkable work. Thank you for what you continue to provide for our patients and contribute to the field of gynecologic oncology. Really, truly outstanding role model for many. Really appreciate you, Nicole. Thank you.
Thank you so much, Pedro. You are our role model, and what you did with this International Journal of Gynae Cancer, I don't know, did you double, triple, or I don't know the impact points. It is
Quadruple.
absolutely amazing. Quadruple. So thank you very much for this invitation. It's always a pleasure and a joy to talk to you, and I hope to see you soon again.
Thank you.